actually
Okay.
some law.
I'm sure they have you can use this.
start anytime you get ready to. We're up and live.
This is a whole new stage fright kind of thing. People I got used to, but cameras I haven't. Ready? Good afternoon. My name is Ronnie Rowan. I'm one of the intensivists at St. Vincent's East in Birmingham, Alabama. Me and my partner and I are both board certified in neurocritical care. We're going to talk about ICU management of the acute stroke. First and foremost, have no disclosures. And then I'll just go through my references. Essentially, this is going to be a rehash or a highlight of various stroke recommendations from the American Heart, and then a couple of trials. This is the one on intracerebral hemorrhage. This is the guidelines for acute stroke. It's updated, well, most recently updated in January 2020 of the 2018 guidelines for ischemic stroke. This is a study about blood pressure lowering, and also a repeat study that we will discuss briefly. And then more guidelines from AHA about swelling and increased intracranial pressure. Neurocritical care articles on prophylaxis and EVD management. And then all of these are broken down into recommendations based on level of evidence and type of recommendation. This is the way that I kind of interpret these. Class 1 is the things that are kind of no-brainers and you definitely should do. Probably do Class 2A, 2B, consider, and then Class 3 is don't, either based on no benefit or from harm. And then the level of evidence, level A evidence, pretty solid. B is likely, and then C can either be just common sense that nobody would bother to study, or expert opinion. So we'll start with intracranial hemorrhage and looking at the different distributions, the putamen being the most common bleed, followed by lobar, thalamus, cerebellum, and pons. And then I have, generally when there's a live audience, I have a live audience response, but we don't have that here. So this is the question, and I can tell you just traditionally, it's about 50-50 is kind of the response to many of these, so we'll kind of see where you fall. So achieving a blood pressure goal less than 140 is critical for improved outcomes and prevent hematoma extension. So you can log that answer and then we'll discuss it. So there's two studies that particularly address this issue, Interact and Attach. They were somewhat similar. The Interact looked at systolic, trying to keep systolics less than 180 versus 140, and you could use essentially any drug that you chose. The Attach had similar goals, but they had more defined ranges, but essentially under 140, under 180, and they used exclusively nicardipine. The outcome, or the treatment arms, you can see that were pretty consistent. I mean, they achieved their goals, and then we review the outcomes. And looking at the Rankin score for both of these studies, they were about the same. It didn't matter if your goal was less than 180 or 140. Your outcomes were very similar, long-term outcomes. They almost mirror one another. So what that shows us is that you can safely lower the blood pressure, and it doesn't affect your mortality. In the Interact, it had very slightly differences in Rankin and hematoma size, but not considered clinically significant. So our goal is 140, is what we target. So I figure if there's not a big difference between 180 and 140, 140 might be, if a goal of 140 might be a little bit superior, and we target 140 as the goal in intracerebral hemorrhage. So the official recommendations for intracranial hemorrhage is if the blood pressure is significantly elevated up to 220 from 150, lowering it to 140 is safe, and it may be effective for improving control or functional outcome. Greater than 220, it's a little bit of gray area. Those patients aren't going to be well studied. They're probably outside the parameters of most studies, but you should still consider blood pressure reduction in the neighborhood of about 25%, probably using continuous infusions and frequent blood pressure monitoring. And that was a class 2B, level C. You can see the revised meaning of the most recent guidelines. That was a bit of a change. So for ischemic stroke, that was prior was bleeding. This is ischemic, and the data is a little bit conflicting, and it's not as clear. Lowering the blood pressure too soon is probably harmful. But at 48 to 72 hours, it's reasonable to start beginning to lower the blood pressure. I don't know if you remember, 25 years ago, acute lowering of stroke caused a lot worsening strokes. It's associated with procardia, was commonly implicated in those cases, and that's often that's when permissive hypertension started coming into play. Now, you still want to lower it, you got to get it down, but when to do it in 48 to 72 hours is probably the reasonable time frame to do so. In the natural evolution of stroke, initially the blood pressure will be elevated, but it tends to naturally decline after about an hour and a half. There is no particular guidance on agent choice. Hypotension is a rare complication of stroke. The important thing is you need to rule out other causes because it's unlikely to be the stroke. It could be, but it's unlikely. And if they're hypotensive, you've got to maintain perfusion pressure to preserve brain cells and rule out the underlying cause or identify the underlying cause and treat it appropriately. Sepsis probably being the most common. For acute stroke, embolic stroke, TPA candidates, you're going to lower, in those patients, you'll lower to less than 185 with a diastolic less than 110, and then you need to maintain that before and after TPA to less than 180 over 105. If the mechanical thrombectomy, patients, I would treat them similarly. Same goals as TPA, and then and for 24 hours after the procedure. There's two protocols recently developed, and they like to maintain an increased systemic pressure or systolic pressure greater than 150 while occluded, and then 140 after reperfused is another protocol. Somewhere again targeting that 140 mark. You're never going to be precisely perfect on your management and targeting, but having a reasonable goal is ideal. Non-TPA, this is where we get into permissive hypertension. If it's less than 220 over 120, you let it alone. Start lowering that blood pressure at about 48 to 72 hours. If it's greater than 220, probably target around 15% is the right number, or we think the right number. Then during the first 24 hours, and then you would gradually lower that over time. The complications of different comorbid complications, it's going to be a risk-benefit analysis of what to do. But say if you have your blood pressure is 215 and they have an aneurysm, you're just going to have to probably split the baby. 15% is a reasonable, considered safe, a reasonable goal of lowering, but you've got to take all these factors into play and come up with the best decision that you can. Agents, we'll review briefly. Labetalol, everybody's pretty familiar with that. We use 10 or 20. We do it every 15 minutes until you get control. You can use an infusion of 2 to 8 is the range. Nicardipine, easy, it's becoming very commonplace now. It's fast, titrated, generally every 30 minutes or so. Clofidipine is very similar, has a similar mechanism of action as nicardipine, but it is faster on, faster off. It's also titratable infusion. Hydralazine is dosed very similar to labetalol, a little slower onset, so you have to be a little more careful because you can dose it, not get the effect you expect, and then you're redosing about the time it actually starts to work. And then nitroprusside, classically a control agent, but really not used very much anymore. Lots of side effects, large blood pressure swings, and it can theoretically increase your ICP, and I would say in general it is out of favor. Complications for a stroke, these are the things we deal with in the ICU. These are generally arranged according to the time frame in which they occur, although of course you can move them, they can move all around. But we'll address each of these as we kind of move through the talk. So a audience question. So PCO2 of 30 in an intubated patient decreases the likelihood of developing increased intracranial pressure, and this applies for both bleeds and ischemic strokes. So the recommendations is to maintain normocarbia and not do prophylactic or preemptive hyperventilation. You want to intubate patients with decreased mental status that are not oxygenating well or can't control their secretions. These patients are at very high risk of aspiration and pneumonia, subsequent pneumonia. A saturation of 94% or greater than 94% would be a reasonable goal. You can use hyperventilation as a bridge. So if you've got somebody developing increased intracranial pressure, you may want to briefly hyperventilate that patient to allow time to do other therapies to more definitively treat it. But maintaining it is not going to be beneficial, and the brain adapts to that, and then you progressively have to go work more and more hyperventilating in order to achieve your goal, and ultimately it's just not recommended to do. Temperature, it's important to avoid fever if you can. Maintaining normothermia, you should treat hyperthermia aggressively. It's similar to what we do, somebody has cardiac arrest, you cool them for neuroprotection. It's really not much different in this case. And I say we cool them, we basically prevent fever, and that's the same goal here. And you can use cooling strategies, Tylenol, antipyretics, that kind of thing. Hyperthermia has been reserved currently, as the recommendation is to reserve it to studies. Tight glucose control. It has superior outcomes to more loose of 140 to 80 goal, but has more hypoglycemic complications. True or false? There's probably not a definitive answer on that, but hyperglycemia should be avoided. So the nice sugar goals of trial of 140 to 180 is very reasonable. Tight glycemic control is not recommended. Whether it's better or not is maybe a little bit controversial, but it certainly does have more complications of hypoglycemia, which is another thing that you desperately want to avoid. Insulin infusions can be very useful in cases especially of refractory hyperglycemia. And then diet, you want to get them back and feeding as fast as possible, hopefully within at least 7 days, generally faster than that. TPA, spontaneous or conversion, status post TPA for hemorrhage. This is just the protocol in which to treat that. You want to stop the TPA immediately, get baseline labs, get a CT head baseline, and then you can reverse the TPA with cryo, 10 units fairly rapidly, and then repeat fibrinogen. If it's less than 200, you can repeat it. And then TXA or Amicar or tranexamic acid and amicaproic acid to help reverse the TPA as well. And then, of course, you're going to get the consults that you need is how you would deal with that complication. Angioedema, if they're on an ACE, stop it. Stop the TPA. Very similar to most angioedema protocols that we have: steroids, Benadryl, Zantac, H1, H2 blockers with steroids. If it's refractive, you can add epinephrine. You can add icatibant, which I've never given, but it is recommended for this. And then also C1 esterase inhibitor are options, and continued supportive care. Hyponatremic, so 35% of patients with stroke will develop some level of hyponatremia during their stay. It's more common in hemorrhage than it is in stroke or ischemic stroke. And it's more predominantly SIDH, although it can be cerebral salt wasting. And if it's cerebral salt wasting and it's misidentified or mistreated, the outcomes are quite worse. And I think the reason is because it is less common and it's less recognizable. If you look at this table, they're very similar. The volume is opposite, but nonetheless, that's a very difficult thing to assess clinically often, and we often have disagreements on the extracellular volume status. But the hematocrit, I mean, it's very, increased versus normal, increased versus normal, normal. You see a lot of difficult ways. But the treatment is drastically different, right? One is fluid restriction, the other is replacement of volume and salt. So it's important to recognize one of the biggest things that I find useful is with SIDH, they tend to not have very significant urine output, where with cerebral salt wasting, it's generally copious. But that needs to be, that needs to be identified and figure out, is this cerebral salt wasting or SIDH in the episode of hyponatremia. Seizure prophylaxis is not indicated in the absence of EEG or clinical seizures, and that holds true for, that question is for both ischemic stroke and hemorrhage. Again, the answers to this is generally about 50-50. If they have seizures, you should treat them. So I think that's everybody, we can agree on it. If they have seizures on EEG, also should be treated, such as non-convulsive. But prophylactic AEDs generally are not recommended. It's considered harmful and or, in some cases, or not helpful, in some cases harmful. If somebody is in disproportion to their injury and you think their level of consciousness should be higher than it is based on the damage, those patients need continuous EEG monitoring or at least frequent spots, because having non-convulsive status epilepticus is not uncommon in these patients, so it should be looked for. Hydrocephalus. So EVD should be placed in patients with obstructive hydrocephalus, especially if they have decreased level of consciousness. Probably the #1 indicator to have this done. For cerebellar acute stroke, it's highly recommended, as the space back there is small and they need decompression. You want to maintain a cerebral perfusion pressure of 50 to 70. And then as far as getting rid of the shunt, they've looked at rapid shunt weaning versus gradual. Most places do a gradual shunt wean. They'll take the pop from 0 to 5, 10, depending on how they do, they determine. The only thing, in looking at that, versus just doing it very quickly, the only difference they could find is the length of time that it took to wean the EVD before shunting. So just a FYI there. Extending into the intraventricular space, a couple interesting studies on that. Putting TPA into the actual ventricle, but that's still kind of ongoing as to whether that's beneficial or not. Endoscopic treatment, similarly, it can go in and remove it endoscopically. The benefit of that, again, is uncertain. Steroids. Commonly used, steroids are indicated in stroke if they have signs of increased intracranial pressure. True or false? And in fact, these are kind of the treatment parameters for, sorry about that, for increased intracranial pressure. First of all, you want to put the head up. Make sure the neck is neutral so that the venous drainage is good. You can briefly hyperventilate them in order to, while you're working on some other downstream effects to help. Steroids are not recommended. They're considered a class 3 harmful recommendation. Hyperosmolar therapy, such as hypertonic saline or mannitol, can be utilized, as well as diuretics. An EVD can be placed for drainage. You can paralyze the patient. Barbiturate coma and hypotherapy is no longer recommended and considered no benefit class 3. And then finally, you can move to decompressive surgery, which we'll talk about next. So somebody that has a cerebellar infarct or hemorrhage in the posterior compartment with hydrocephalus from this obstruction needs to be decompressed. For supratutorial, it's probably not as well recognized or known, understood what's beneficial. Early, it doesn't seem to be beneficial, like preemptive, if they're not deteriorating, but if they are, it may be life-saving. And it can help with large hematomas, refractive ICP that you just cannot control, and coma. For acute ischemic strokes, for MCA, large MCA, a large study looking at these patients were essentially resulted according to age. In the less than 60-year-old group, they had a mortality reduction by half, and half of them were walking at 12 months, and 1 out of 5 were completely independent at 12 months. However, you contrast that with the 60-year-old, greater than 60-year-old, the mortality reduction was the same, but only 11% were walking, and there was zero were independent at 12 months. Similarly to the previous slide, cerebral infarction failing medical treatment and EVD should be decompressed. So typically, we will try to stratify our patients according to age based on this information of a 0% independence. The younger, obviously, the better outcomes you're going to have. As the older, a decompressive craniotomy seems less and less likely to be beneficial. And you can see the recommendations, differences of Class 2A versus Class 2B, which would be probably do it versus consider doing it. Infection, a large number of these patients will get a urinary infection. Routinely using catheter just because is not recommended. Pneumonia is very common, very prevalent. These patients should be evaluated by speech pathology to ensure safe swallowing. Enteral feeds within 7 days, hopefully sooner. And if you anticipate prolonged swallowing dysfunction greater than 2 to 3 weeks, probably useful to get a PEG. Routinely dosing these patients with antibiotics prophylactically is not beneficial and not recommended. And there's a lot of evidence that suggests that strict oral hygiene protocols can reduce your incidence of pneumonia. Chemical prophylaxis for VTE should be withheld in bleed ICH, so intracerebral hemorrhage patients, for at least 7 days. I'll let you log that. Okay, so about 10% of stroke patients will succumb to VTE, PTE. And, but they should, so essentially when they come through the door, they should have, as most all patients that are bedbound, should have sequential compression devices to help prevent VTE. After strokes, after you know that the bleeding has stopped, you can start them on DVT prophylaxis, usually within 48 to 72 hours for a bleed, and it's 24 hours for an ischemic stroke. So within 24 hours, you know you have some reliability that they're not bleeding and they're probably not going to bleed. Go ahead and start those patients on DVT prophylaxis. And for bleeding patients, bleeding strokes, after 48 to 72 hours, it's reasonable to start. So systemic anticoagulation or filter, if you have a PE and they have a, so post-stroke PE or DVT, do you anticoagulate them or do you filter them? And it just, I mean, there's no answer. It may be beneficial to do one over the other, what caused it, how big it was. There's just too many variabilities, really, and it's going to be a case-by-case determination. Compression stockings, by the way, have, I think since 2009, have not been recommended and cause harm and really no benefit. This is a unofficial but reasonable approach to initiating VTE prophylaxis. If you have a confirmed intracerebral hemorrhage and they're early mobilized, then that's the best case scenario, and you really don't need to do anything. You can stop. You can do the intermittent compression stockings. You get a control CT. The CT control at 24 and 48 hours, it shows stable, no advancement of bleeding, and they don't have a clinical worsening. You can go ahead and start considering VTE prophylaxis or initiate VTE prophylaxis. We use Levinox unless there's a contraindication. If they are worsening, then continue the SCDs and then just daily evaluate when to start VTE prophylaxis. Some controversies we'll address. That was one. Empiric osmotherapy and anticoagulation. So presence of an EVD is not a contraindication for VTE prophylaxis. So they have an EVD in their head, and is that a contraindication to start Levinox, for instance? And it's not. When you can safely do that, but it needs to be when the risk of bleeding has subsided, typically 48 to 72 hours. If it's stable, you're able to, it's reasonable to provide those patients with Levinox or heparin, mini-dose heparin, or what have you. In the setting of hypernatremia, so a patient comes in hypernatremic after a stroke, you want to correct it with, the question is, do you want to correct it with a hypotonic fluid, let's say D5 or half normal or what have you? And the answer to that is no, you do not. You want to use isotonic fluids, and you want to avoid hyponatremic or hypoosmolar fluids, mainly because that fluid can increase intracellular edema, which usually peaks after a stroke about day 3, day 4. On the opposite side of that, prophylactically driving their sodium up or their osmolality up is similarly not recommended. It is appropriate to do in the context of increased intracranial pressure, but not empirically. Stroke patients with high-grade carotid stenosis should not be systemically heparinized to prevent further emboli. True or false? So, typically not. They should not be. Aspirin is reasonable and should be started on all these patients that you can give it to. But urgent anticoagulation with systemic therapies to prevent future strokes immediately, in the immediate term, is not recommended. And and withholding anticoagulant therapy within 24 hours is recommended. So is not recommended to initiate anticoagulant within 24 hours of TPA. And there's no urgent need for heparinization, for instance, after the acute stroke, ischemic stroke. This is the brain support cycle. Avoid fever, maintain normonatremia, avoid hyperglycemia and hypoglycemia, maintain a normal PCO2 or normal pH, adequate oxygenation, euvolemia, and it will help your brain be strong. Early VTE prophylaxis within 24 to 72 hours, depending on the situation, depending on the diagnosis. Early nutritional support. Your peak, well, that's a peak 1 to 3. I tend to use 3 days as far as a peak increased intracranial pressure. Get them up and moving early, get them mobilized, and swallow evaluated for safe swallow prior to diet, and then your secondary prevention strategies for stroke. And with that, that is it. There's an area on the website that you can submit questions to if you would like. Also, this email is good, and I hope you've enjoyed it.
Is my microphone on? Microphone's on, okay. Hello everyone, I'm Peter Nagy. I'm the Division Director for Pain at UAB in Birmingham, Alabama. I'm going to talk to y'all about opioid stewardship and pain management. I have no disclosures, there's no industry that is supporting this talk today. And I want to open with, the epidemic that everyone is focused on and certainly has gotten our national attention appropriately so. And of course, this is a map of the epidemic and where the states that are hardest hit, the new cases of COVID-19 across the U.S. But I also want us to think about the epidemic that pre-existed, and we can't forget about our opioid epidemic. And what we're seeing now is the coinciding or the collision of these two epidemics and what it's causing. And what we're seeing is an increase in the opioid deaths during this COVID pandemic. And this is an article that was recently put out by the AMA looking at this issue. More than 30 states have reported an increase in opioid-related mortality during this COVID-19 epidemic. And there's a lot of reasons for that, and several other articles and other sources are also reporting on this. And several reasons for this, with the loss of work, the income insecurity, decreased social interactions that we're seeing as a result. These are all stressors that can increase the likelihood of drug misuse and abuse, and all of our harm reduction, or many of our harm reduction efforts, have been diminished during this time. So naloxone is a lifesaver, and we've decreased access to naloxone in many public health facilities that are closed or reduced their hours of availability due to social distancing requirements or PPE availability or lack of funding. We're also seeing many of the supply chains that are normally available, those have been disrupted. And even when there is availability of naloxone, there may be no one around because of social distancing or willing to administer naloxone if someone is afraid that they may contract coronavirus from someone who is overdosing on opioids. Also support groups for those that have substance use disorder and even clinic visits that are routine. They've been canceled or severely limited. Zoom and telehealth are available and are offered in many places, but certainly we all know that that's not available to everyone. There's a limitation in internet access and resources available, and others feel that it's really not quite the same having telehealth visits and groups that are over the internet aren't quite the same. Decreased access to MAT, and in particular daily methadone clinics and others where really you need to have pretty close supervision. Those have been limited again because of the same restrictions, and in order to avoid withdrawal, many patients may be more likely to use illicit drugs. Also, the illicit drug supply chains have been disrupted, and so there's people that are more likely to get drugs from other unfamiliar sources, and it may be contaminated with other substances that are more dangerous. And again, using drugs alone from social distancing or other situations that are forced or voluntary may increase the risk of fatal overdose. And then lastly, the DEA has relaxed a lot of restrictions around prescribing substances, and whether that's in a substance abuse program or even in our clinics and pain clinics and other places where you're prescribing opioids in order to ensure that there's access for everyone. There's less oversight, fewer safety precautions, and that certainly can increase the risk of misuse, particularly as rates of anxiety and depression are increasing in our recent situation. We'll get more patients that are self-medicating with opioids and increases. So what can we do about it? First of all, looking at how we've gotten to this place with opioid prescribing and really taking responsibility for it. And I think this is an old one, but it's a really good graphic looking at the U.S. prescribing patterns. And we are 4% or 4.5% of the world's population, and yet we prescribe 80% of the world's opioids, which is pretty alarming. And in Alabama, we are the highest prescribers. We're catching up to Arkansas there, but you can see here we still have the title. I think football and opioid prescribing are what we're best at. 97.5 prescriptions per capita in our state, and the amount of opioid prescribing cannot be attributed to our underlying health population. Those things have been adjusted and have been looked at, so it's not because we have the sickest patients or the most pain of anywhere in the U.S. The influences and how we, how we ended up prescribing so much, and there's a lot of people that have looked into this, books that have been written, articles that have been written, and it's a interesting stories. There's a lot of whether third parties that have made huge profits from this. Sackler family has been a target from, they started Purdue, and their OxyContin marketing was one of the biggest kind of leaders in creating this opioid crisis. And that's a very, it's an interesting story there. And certainly even our own, whether it's a Federation of State Medical Boards or other pain associations bought into this as well. There was much of our standards and the expectations for prescribing through the 2000s related to using opioids, and they could be used safely and efficiently, or excuse me, they were safe and efficacious despite a lot of evidence to the contrary. Many small studies, and you can see some of these that have been touted, small studies that showed benefit were advertised and really influenced the way that we prescribe broadly. And you can see here even the state medical board was influenced by some of the donations from pharma. And then other demands on clinicians, of course, patient satisfaction and throughput demands. Patients that, they come to the doctor, they want something, they expect to get a prescription for something. And so all these things have contributed to why we have overprescribed. And there's an axiom here that it takes 30 seconds to write a prescription for Norco, but it takes 30 minutes not to prescribe it. So that's one of those things that we really have influenced the way we prescribe. And until the past few years, we really were on the wrong course in getting up in our prescribing for patients. So, as this information came to light, you can see here there's an inflection point, and we have started to improve. And in Alabama, we've just like in the country, we've decreased our prescribing over the past 5 years. This is the latest that our data is available. But Alabama still has the highest prescribing in the country, and we prescribe really almost twice the national average of opioids. And we know that prescribing opioids for patients can directly lead to other forms of misuse, abuse, addiction, and even heroin use. And this was a study looking at heroin users, and what they found, 86% of urban heroin users started off with prescription medications, and they might have started it either from their own prescriptions that were given to them, or from family and friends that they obtained prescriptions from. So this was an interesting article and this is the American Journal of Drug and Alcohol Abuse, and it looks at there's multiple surveys and published studies, and it was looking at non-medical prescription opioid use as an infectious disease, and certainly in our era of this pandemic, looking at anything as we're all much more familiar with infectious disease spread. So what they looked at was a susceptible, infected, and recovered epidemic framework in which people initiate non-medical opioid use, transition to paying for opioids, then tamper with them, and eventually transition to heroin. So this, because it seems like a far stretch, and how can a prescription that you're writing as a physician for what seems like a legitimate ailment end up contributing to the heroin problem and opioid overdoses that we see. But this model was able to simulate that and was at least able to put this in a little bit more of an epidemiologic framework where we can understand how this could happen. And what it looked at is prescription opioid use. It starts with an exposure by a legitimate prescription or peer influence or social exposure. And what they found is that susceptible individuals were those who had never been exposed to opioids non-medically, and infectivity was the likelihood that contact resulted in infection. So if somebody could convince you to try it, how interesting that idea was, or if you were just susceptible by your nature. And the contact tracing, certainly as more people, as the number of recreational users grows, the susceptible group will have multiple contacts, and the likelihood of spreading spreading like an epidemic can occur. And you can have positive feedback where more people that are exposed, and they go and find their, look in their medicine cabinets and their family members' medicine cabinets, and eventually, though, you will get to a point where people that are using these medications will exhaust the supply that's immediately available to them, and they'll start looking for other sources, and that's when you get to the point of someone that looks to go buying the pain pills from other sources, and eventually you can see how it can transition from buying to tampering and price shopping, and you end up where you're buying things that are quite dangerous. And this framework and what they used did accurately predict, and you can see here their predictive model versus actual, the number of patients that were, or people that initiated non-medical prescription use, and also recreational users over time. So, and what we see here, the more that you're using opioids and the more exposure in particular to illegal drugs, you will see this correlate with overdose deaths. And this is Alabama's overdose death rate as compared with the U.S. death rate. And you can see it age adjusted. In Alabama, we continue to go up. We're up by 10%. In the last year that data was available. And where the opioid prescribing is happening can be tracked. And this is something that the CDC has been really helpful in providing very granular data about, down to the counties and areas where you can see the opioid prescribing in certain areas that have the highest. And you can see in Alabama, it's Walker County. You can also if you go to this cms.org site, you can also actually look by provider. So there's there's very granular data here. You can look in, you can actually enter a provider specifically, and it'll give you the Medicare Part D prescribing data to identify patterns, and that's, here's my information here. You can see prescribing of certain medications. Also, there's a lot of data available through the PDMP, and Alabama has this PDMP that tracks providers' prescriptions and sends us feedback. We get these reports every 3 months in our email, and you can look very specifically at prescriptions by daily MME in these categories. You can also look at the duration of these prescriptions and the volumes of these prescriptions, and also anxiolytics, so it's not just opioids. It also looks for benzodiazepines and other sedatives, and in particular the dangerous combinations of benzodiazepines and opioids. So very helpful. Also, lastly, the ProPublica, it has a really nice website where you can look at prescribers, and in this, you can look at who has the most, who's the highest prescribers. You can look at the highest drugs, and you can see here in Alabama, hydrocodone is the #1 medication that we prescribe. It's higher than the omeprazole and the blood pressure medication. So, and you can look at by specialty, but that's pretty alarming that is the #1 prescription that we're prescribing. And you can also look at who's prescribing it, who the highest prescribers are, and these are our highest prescribers in the state of hydrocodone. And, of course, with the high prescribing and all this granular data, you end up seeing some of the news headlines that come out, and certainly that's what law enforcement is looking at when they're seeing providers that are overprescribing, in particular without bad outcomes. You end up on the front page of the news or the headline in the news stories. But it's not just the pill mills. That really any provider can be susceptible to to a bad outcome with opioid prescribing. These are high-risk medications, and this is an article that was in the paper looking at academic medical centers that were sued, and this is a bad outcome, unfortunately, that these prescribers that the lawsuit accuses that these providers and actually the clinic themselves, there was corporate negligence for failing to oversee the doctor. So it's not just the providers, it's also the academic institutions that they're part of if there's not a good corporate oversight and policies in place. So that's certainly something that that there's some attention being paid to should hospitals be responsible for opioid addiction and some of the bad outcomes of that are happening. So how do we prescribe appropriately? How can we be careful in this time when there's so many things to be concerned about, and what's the right things to do? Well, the CDC has provided us this information, and there's really there's no better way to talk about this and to kind of go through those, and I'll fly through these. Everybody's been hearing about these for the past couple of years, and so I won't spend too much time individually on these, but it is, I will say that these recommendations, initially they are voluntary recommendations that were intended for family practice and internal medicine doctors. But I will say in many, with a few exceptions, they really become representative of the standard of care for all providers, and not just internal medicine and others. Many our pain doctors in our clinics all follow these guidelines, and so I would contend, and I think they what we've seen is this becomes the standard for all opioid prescribing, and you can see that medical experts and licensing boards, judges, and others, they can interpret these guidelines as the standard of what a reasonably prudent practitioner might do under similar circumstances. So it's not just a voluntary guidelines. But that said, there are the caveats, and the CDC actually they published this as well, and this was in the New England Journal just recently last year, that they did not want these guidelines misapplied. So they specifically articulated that this was not intended for patients outside of the guideline scope, so active cancer treatment, sickle cell crisis. And they actually write post-surgical pain here, but we'll talk about that in this talk. Also, they don't support hard limits or cutting off opioids in patients, and clinicians, and they write in here, clinicians should avoid increasing dosages to over 90 MMEs or carefully adjust beyond that. And they also do not support abrupt tapering or sudden discontinuation, which can result in opioid withdrawal symptoms, including pain and psychological distress. And this does not apply to patients receiving MAT for opioid use disorder. So what are the guidelines? They're broken down into 12 recommendations in 3 areas, and I'll go through those. I mean, first of all, the opioids are not first line, and I think we all know that. Really, we should be using non-steroidals, other safer medications, acetaminophen, non-pharmacologic therapy, and when we can. And if opioids are used, use those in combination. And so there's a lot of options there, and you can see here benefits and harms are listed, and typically you'll get benefit with minimal harm in some of these non-opioid analgesics. Looking for goals of pain and function, so not just pain scores. Of several years back, that was really the only focus, and seems like what the focus of much of our escalating opioids was focused on pain scores, but now it's really much more about function, making sure that you're incorporating some assessment of function along with their pain score and their activity levels, discussing the risks and benefits, and when previously a lot of the literature was talking about the benefits only, really we must weigh that with the risk as well. And this is our old controlled substance, our opioid contract that we had with, what we used to call them, now it's an opioid substance agreement, but it said here that, and this was the one that we used for many years, that dependence and addiction is very rare, and that's what we told patients as we prescribed them opioids and gave them this. Well, that was misguided. This is an article that was published in 2014 looking at that, and this is, again, many providers were taught that there's no chance of addiction if you're using opioids for legitimate pain. And I know I've told many patients this in past years, that they're not going to get addicted if they're using it for real pain. Well, what this study looked at 500,000 patients aged 18 and over with a new chronic pain non-cancer diagnosis. And what they found was that a single prescription for an opioid increased the patient's risk from an opioid use disorder by 3 times. A low dose chronic opioid prescriptions increase their risk by 15 times, and high-dose chronic opioid therapy increased the risk of an opioid use disorder by 122 times. So does not have the caveat that this is a legitimate pain, or you have rheumatoid arthritis or other. If you're on high dose long-term opioids, your chances of developing an opioid use disorder are very high. So it's a strong risk factor, and duration of opioid was more important than daily dose even. So that's one thing that we just have to recognize, that there are risks associated with prescribing, and not just opioid use disorder. There's certainly other risks from the endocrine system and others, but I won't get into to those. Prescribed short durations for acute pain, and this is because long-term opioid use often begins with short-term prescription. So what they recommend is 3 days or less will typically be sufficient. More than 7 days will really be needed. And what they saw, and this was a study, this was published in the CDC's journal here, looking at the probability of continued opioid use. And it is, you can see this, it's really directly proportional to the number of days. Here's the days supply versus the probability of the patient remaining on opioids for 1 or 3 years. And this, they're directly correlated. And this is another study that was all patients. Well, even if you look at surgical patients, and as an anesthesiologist, that's certainly something that we think about quite a bit. If you look at surgical patients, you think there's a legitimate population of patients who need opioids. So can that still hold true? And this study looked at that specific answer, and what they found, 7.7% of patients who were opioid naive that were prescribed opioids after surgery were still taking opioids at 1 year post-op, which was 44% higher than a matched cohort that did not receive post-op opioids. So even for low-risk surgery here, and I'm not sure how well you can read that, but even there are patients that were getting opioids for cataract surgery, and certainly laparoscopic and other minimally invasive surgeries. And they found that prescription for opioids after low-risk surgery was associated with long-term use. And that was this is a Medicare database, and so you can argue that these are older patients, maybe have other reasons why they would have pain and osteoarthritis and other things. And this is a different study looking at that same question of post-op opioid use. And these are younger patients here, all below 65. Again, some of them got prescriptions after a minor procedure, others got prescriptions after a major procedure. And what they found was, these 36,000 patients that met inclusion criteria, the rate of new prescription opioid use was similar. And it didn't matter between minor surgery and major surgery. Still about 6%, 6 to 6.5% of patients were still taking opioids after 1 year. And what they noticed is that this was the incidence of persistent opioid use in the non-operative control was much less. So, other factors that they found that were related, the risk factors, independent risk factors that they found, preoperative tobacco use, alcohol substance use disorders, mood disorders, anxiety, and preoperative pain. So what they concluded was that persistent pain after surgery was not significantly different between minor and major procedures. So it's not a matter of how much pain you're having, but what they found is more associated with behavioral and other pain disorders that suggest that this occurrence is not a surgical problem, but it's other patient level predictors are involved, and it can be pretty complex. And what we've seen is that our prescribing patterns are also not consistent with the amount of surgical pain that patients are having. This is a study in JAMA that looked at 18,000 patients, and they looked at their 24-hour opioid use versus their prescription that they were given on discharge. And what you can see here, this big blob here in the center, there's a lot of variability. There's no consistency in how patients were prescribed. So there's a lot of variability, and it did not correlate with the patient's pre-discharge opioid use. So here's a 24-hour opioid use, and you can see here what's really interesting. These patients use 0 opioids in the 24 hours before they're discharged, and this is logarithmic. This is a large, big prescriptions that are being sent home with these patients, despite the fact that they didn't use any in the 24 hours before discharge. So, it's our prescribing patterns that need to be analyzed and really rethought. So, using immediate release opioids when starting, and that's another important caveat. Most of us are doing that. I think that most practitioners are going to use short actings, but there was a thought there, and certainly in my training, we felt like the long-acting opioids were safer, and that's why we prescribed them, and really there's no evidence for that, and these studies showed really there's no significant difference between long-actings and short-actings are not safer or more effective than intermittent use of short-acting. So, and there's also no evidence that scheduled long-acting opioids are reducing the risk of opioid misuse or addiction. So, using the lowest effective dose, of course, and that you can, and developing policy strategies in your practice is going to be important. Use caution when going over 50, and avoid increasing over 90 if you can, if it's non-cancer patients. So, and the reason for this, and there's several other studies that showed this type of information, but we know that mortality can be linked to the higher doses. So this is, you can see here, over 200, you have a much higher rate. From 100 to 199, your death rate is higher. And then as you get closer, down to the below 50, it's much closer to baseline. So certainly dosage has risk, and the higher doses carry with them also a higher risk. Evaluating the benefits and harms frequently. So once you start a patient on opioids, if they need to be on opioids, assessing them regularly, making sure that the initial benefit that you may have seen is still there as you get further and further out. And sometimes you will definitely see patients that respond and do really well with opioids in the short term, but long term that effect fades, and then they need to be reassessed, and maybe other alternatives, and coming off of opioids may be the better option. So we did that in our clinic, and this is some of our data. In our pain clinic, we tapered patients we actually started a little before the CDC guidelines, but over a couple of years, we really looked at this going very slowly, having a lot of conversations with patients, and this was despite, we're seeing more patients. Our daily doses were decreasing, and we slowly weaned patients down, and we, of course, our hospital and our clinic, we're assessing patient satisfaction scores. That's always been an important consideration, and we did not see a significant decrease here. You can see it's pretty flat. Our satisfaction didn't change, and it always has to do with how your relationships and your interactions with patients, and making sure that we're in this together, and they recognize that that's the reason why we're doing this is not for fear of anything. It's really for the risk and benefits, and because we think this is the right thing and the patients will be better in the long term. So strategies to reduce risk for those that need to be on opioids, providing naloxone. That's a really important thing that can be available, whether it's an accidental overdose or from many different reasons. If it's high doses, or if it's patients that have some comorbid disorders, whether it's sleep apnea, old age, and other substance use disorders. These are all risk factors for overdose. And those patients, we provide them a prescription for Narcan. And that's something that even just that conversation of telling them that you need Narcan, you have these risk factors, oftentimes is enough to make patients recognize that maybe this is opioids, or the dose of opioids they're on may not be the best option. So it's certainly worth the conversation. Other ways to assess this, so not just those comorbid conditions, but that you can do surveys, and we certainly, not these surveys, these questionnaires, so we certainly, every patient that's on opioids will get an opioid risk assessment, and some of these other risk mitigation strategies, reviewing their PDMP and making sure that there's not prescriptions that are being given by other physicians, and urine drug testing, regular testing patients. Depending on the dosage, we have an algorithm. If the patients are on higher doses, then we certainly are going to check more frequently. And then whenever possible, avoiding concurrent opioid and benzodiazepine prescribing, and there's risk associated with that. There's several other studies. This is one that was that stood out from the VA, looking at retrospectively at patients who died from an overdose, and what they found was that 50% of the deaths that they had occurred with veterans who were concurrently on benzodiazepines and opioids, and this risk was increased 2.3 times if they had a history of prescription, and 3.8 times if they had an active prescription. So, and this increased as a daily dose of benzodiazepine increased. So certainly those are risk factors that we should be well aware of. And then offering treatment for opioid use disorders. If you suspect patients that having that's developed a dependence or an opioid use disorder, 12 steps is of course one option. There's many other programs, and really getting them in with a specialist where they can get some support, maybe a medication-assisted treatment or otherwise. So opioid, so working together, I think the other one was an accidental slide there. The, how do we find the, what are the common goals that we all have, and how do we work together to find solutions? And really that's what our whole focus of opioid stewardship in our institution and many other institutions have based. How do we educate, whether it's clinicians, pharmacists, patients, everyone being on the same page and taking a shared approach to the use of opioids that recognize they certainly have benefit, but there's also significant harm, and looking for non-opioid options that can lessen that harm whenever possible. And in our institution and many others, there's a lot of different stakeholders that are involved, and many different ways to organize these. At UAB, we've created an larger opioid stewardship committee that a lot of our agenda is driven by a steering committee. We have a full-time pharmacist and a program manager, and this reports up through our quality subcommittee and to the board. And some of the things that we've instituted to address this across our health system is with patient education, and certainly that's where it always starts, making sure that patients are aware. We have videos and brochures that can be helpful for this, and talking with patients in particular is one of the most important. Nursing education, and nurses are of course going to be a critical component of your education and your opioid stewardship program, so they can talk to patients about goals and expectations, explain how they'll be assessing and treating pain, and many of these things that can be instituted without a doctor's prescription, whether it's music therapy and art therapy and other explanations of things that can be done. And we have resident and faculty education programs so that all the physicians are on the same page, and all the prescribers also can be aware of the risk if they're not already. We want to make sure that there's some uniform information that's out there so we can all be on the same page. This is all on a website that we have one internal website with much of these resources and videos and some of the common strategies that we're using that can be shared. We also have one, and this is under development, that's an external site that can be accessed by any providers, and there are more to come in the very near future, but this has to do with some of the research efforts, some of the clinical resources, all the things, community outreach programs that are out there relating to opioid stewardship and addiction resources. Our state and many other states also have this available, and this is also the opioid stewardship. Through the Alabama Department of Mental Health. There's a toolbox, there's videos available, there's printable and downloadable brochures and things to hand patients. So there's a lot of resources out there available, and if you take the time looking for them and making sure that that's part of your practice and you implement that. Our EMR can be really helpful, and that's another big target of our stewardship committee was looking for how we can help providers and others and getting the right information to them. So knowing our inpatient opioid equivalent calculator, that was something that it took some time for us to implement and organize, but really were prescribing without knowing how much we were prescribing for many years. And so now this is something that provides daily doses, so you can really see it graphically and the pain scores, and there's risk factors that display, so if the patient has multiple risk factors, we'll be aware. Of course, if they've gotten naloxone or other. And there is a PDMP outpatient calculator, but we'll link that into our EMR as well. We've also begun e-prescribing, and that was mandated as of last year. That's also a much better and safer way to prescribe, where you can have everything that is tracked in. Also, some of the safety mechanisms, so it's not prescriptions that are written prescriptions that are really much harder to safeguard in many respects. Many things. There's a lot of things that our EMR has implemented that seemed to take more time. This is not one of them. This has been a really convenient thing for all of our providers. It uses two-factor authentication, but if you can, everyone has experienced the times when their prescription is either there's a mistake on it or some other problem with it, and with controlled substances, that patient would have to drive, and sometimes from quite far away, to get a new prescription. Pharmacies couldn't accept them by fax, and there's so many problems with it. This has solved all those, and it's much more convenient for providers and patients. So we've really been happy with that. We've also revised our order sets. And now it's, we're lower default settings. We've got, we're allowing, certainly putting easier access to non-opioid and integrative options, so that those are easier to find, and decision support tools are ways that we can facilitate lower prescriptions. The PDMP is of course, our drug database. That it used to be, you had to leave our system and go and log in. It was quite cumbersome and took a good bit of time, and now that's been integrated into the EMR, where you can one click, you're already logged in, and the patient's data pulls up automatically. So it's much more convenient, easier to access. Or your EMR can really facilitate a lot of advantages, and the PDMP now has this NARC-X score, which is also a helpful tool to use for prescribing and mitigating risk. And it will tell you, based on number of prescribers, number of pharmacies, the MME versus the LME, which is a lorazepam milligram equivalent, and overlapping prescriptions. So there's risk, and based on that, you can see the likelihood and the odds ratio of unintentional overdose, and you can prescribe Narcan based on those numbers. And then there's a dashboard, and this has not been released yet. It is still being validated, but it will be. We will be using this in the very near future, looking at opioid administrations for mild pain. We certainly don't want to be prescribing opioids as a first line. So, looking at how we're prescribing, looking at prescription opioid discharge prescriptions that are more than 7 days, or combinations of benzos and opioids, and then daily OMEs. And again, this disclaimer here: this is not meant to be punitive, or is not intended to indicate poor performance, but it's certainly something that we can find some opportunities for improvement. And it's not just UAB's EMR and our system. Really, we're seeing third parties everywhere that are also looking at very similar data. And this is the Blue Cross Blue Shield provider dashboard. It also has opioid. It has an opioid pain management tool, and there's analytics looking at prescription patterns and prescribing history. And they have this RIM tool that also utilizes some of these quality metrics, looking at prescribing based on these factors: multiple drugs, polypharmacy, multiple prescribers, behavioral health diagnoses, and ER visits. So all these things, and you can see a histogram here comparing you to other providers in your specialty. So they will eventually tie this to other to other like incentive programs, so that there will be certainly some consequence to the prescribing or motivation to prescribe safely. And this, not just for those financial incentives or others, it really, many of these things have been mandated. And in our Alabama Board of Medical Examiners has really started this pretty early, back in 2014. They were the first rules about pain management, and despite this, we're still the highest prescribers. But I think we've done things from a statewide level, looking at how you can recognize and identify where this is coming from. Top prescribers have to register, and that was even back in 2014. The evaluation of patients must include an H&P, goals of improving patients, an H&P that documents why they're getting a controlled substance, and your goals should be also improving their function. You had to have an agreement for an informed consent, an agreement for treatment and a prescription refill policy, periodic reviews. These REMS policies, so it was updated in 2017 to mandate that you're using some types of risk mitigation strategies, and those are being implemented. So including the PDMP monitoring. So if you're over 30 MMEs, prescribing you must query at least twice a year, over 90 every time you prescribe, and some opioid-specific CMEs, which this hour should count towards that. Also, in 2018, they also amended to recommend that physicians reconsider co-prescribing benzodiazepines and opioids, or decline adding a benzo when prescribing. Other industries have also initiated and implemented some of these opioid stewardship efforts. The Caremark systems and through CVS have limited some of the prescription prescribing. Alabama's Medicaid has also limited the dosage for prescribing, and their limits here is like 250, so it's still pretty high, but those limitations have been put in place. And Walmart, for a while, they were planned to require electronic prescriptions. They've had to push that back because of access. A lot of offices were not able to comply. And beyond that, even from a legislative standpoint, this is something that this is a bill. The support bill was passed in a rare bipartisan bill that was passed in 2018, October 2018, and through this, CMS updated its policy. There's a lot of pushback from providers and health systems that said that these patient satisfaction surveys that's some of the reasons that we were overprescribing. Well, those questions about pain have been removed as of October of 19, so that's no longer in effect. Also, this bill recommended CMS review its payment policies for certain non-opioid treatments to make sure that there is access to non-opioid treatments, and they recommended the establishment, or they mandated the establishment of a technical expert panel to review quality metrics associated with opioids and opioid use disorder, to review existing measures, and to include them in value-based payment programs, best practices for patients in the surgical settings, and within 1 year to make recommendations for broader implementation of pain management protocols to limit the use of opioids in the perioperative setting. And the reason for this is, you can see there's a lot of information out there, and this was, I thought, a really interesting article that was in the Health Affairs blog. So after a pain management summit, healthcare leaders were alarmed by the frequency of post-operative opioid dependence as compared to surgical complications. You can see here surgical site infections, which we've put a great deal of resources towards preventing post-op infections and all the processes that we put in place. Well, now those infection rates are as low as 1.9%, but as we talked about, post-op opioid dependence is 6 to 8%, so it's certainly a much higher complication than surgical site infections, or certainly can be considered that. And if you look at that, post-op or persistent opioid use following surgery could be considered a patient safety concern. It meets criteria for CMS as an hospital-acquired condition. If it arises during the hospitalization, it's a high-cost and high-volume condition, and it could have reasonably been prevented through the application of evidence-based guidelines. So certainly that's something that we're going to see more of in the future. And so I'm running short of time, so I will try to keep moving here pretty quickly. So being a leader of care and being a leader of change, and that's certainly something that we're trying to do in our institution, and many others are doing this as well. As an anesthesiologist, a lot of my focus in my practice has been in the perioperative setting, but one of the things we've done in our PACT, or preoperative clinic, is looking at some of the risk factors, and one of the questions that we ask all our patients is about some of the risk factors for opioid overdose in that postoperative period. And the rationale for this is certainly we know that preoperative opioid use can worsen postoperative opioid pain, their surgical outcomes and length of stay, and financial costs associated. And conversely, there's some evidence that preoperative opioid reduction may result in substantial improvements in their outcomes. And so some of the things we've done is talking to patients about weaning off their medications, and whether it's their providers doing that or us talking to them about it as part of a larger, prehabilitation program or perioperative optimization program. And not only opioid weaning, but some other risk factors, tobacco cessation, nutrition, managing expectations, sleep hygiene, all these things, really, they take a lot of work, and it's a lot of additional effort. But for those patients and health systems that are willing to commit that effort, it certainly can improve their outcomes and their surgical experience. And there's other tools that can help with this, if it's weight loss classes and other things that can help, smoking cessation classes, and even now some of the apps that you can use. And there's a lot of downloadable apps, and this is Seamless is one that certain service lines in our health system have been implementing. Seamless will send you reminders about whether it's breathing exercises or other things that may help, or taking medications when necessary can help you in the post-operative and perioperative time frame. Other things we can do as anesthesiologists, certainly there's a lot of adjuvants that can be prescribed, and we're doing that in our preoperative clinic, making sure that patients are using non-opioid adjuvants when possible. There's a lot of different studies and a lot of different adjuvants that are out there, and I won't go into those, everything from the gabapentinoids, the lidocaine. Ketamine is one that's also we've had a lot of success with, and there's now some pretty good guidelines out there about using low-dose ketamine in the perioperative period and post-operatively continuing those infusions are non-opioid. It preserves the patient's respiratory drive, and in particular in patients that have higher opioid requirements or getting large surgeries, multi-level spine, open thoracotomies or laparotomies. Regional anesthetics, of course, are an excellent and one of the best ways to control pain without opioids, and those need to be tailored to the surgery the patient is having, whether it's a regional nerve block, and our numbers have gone up significantly. ERAS protocols are these enhanced recovery protocols after surgery, and this is a collection of best practices. Many of them are focused on post-operative pain, but it has to do with the pre-admission education, standardized anesthetic protocols, and specialized post-operative care. And we have quite a few of those ERAS pathways that we've implemented with significant success. This is one study that we did internally. It was really looking at our knee and hip replacements, and what our goal was to standardize some of the care that was provided. We were using too much of the PCAs, the patient-controlled analgesics, post-operatively with these patients. And so what we did, we implemented a standard protocol, including patient education and neuraxial block. So these patients were getting spinal anesthetics plus regional, so they were getting a QL block for the hip replacements, or a continuous adductor canal with an IPAC for the total knees. And what we were able to do with implementing these pathways, along with patient education, multimodal analgesia, we dramatically reduced, this is the PCA utilization, you can see from 93.64 down to 10%. And even for this short 6-month interval, we were down to 1.6%. So we really had pretty dramatic reduction in their PCA utilization. And that was all without, that was also facilitated earlier discharges. Here you can see our post-op day 2 discharges were increased substantially versus most patients being discharged on the 3rd day previously. I even had some going home on day 1. Length of stay actually fell below the expected there for a short interval, and their length of stay went down, which is substantial, and there's no change in readmission rate, so that's important. Along with that, you can implement these really effective ERAS protocols and perioperative management protocols, and this is one study I thought was really interesting, looking at, you can see here, this pre-op, intra-op, and post-operative care pathways, and it's a really nicely done ERAS program. But what they looked at was opioid use in patients that underwent these ERAS protocols, and what they found in this study was a dramatic decrease in the hospital administration of opioids, but they did not see any difference in discharge prescribing. So you really have to combine this, because otherwise just these perioperative protocols by themselves won't change your prescribing patterns without a deliberate focus on that. So in this study, they showed even patients no preoperative opioid use, low pain scores, and low MME consumption because of all these nerve blocks and non-opioid analgesics, 72% of them still went home with an opioid prescription. So ERAS would decrease their opioid utilization but didn't impact opioid prescribing. So with that in mind, we took one of our ERAS protocols for the gyn-onc patients, and we followed it up with a focus on opioid prescribing. And our goals were to create some common guidelines for prescribing, making sure that non-opioid medications were being utilized effectively, and encouraging safe disposal of unused opioids, of course. And we created a tiered prescription, discharge prescription pathway where patients getting minor procedures didn't get an opioid. They just got acetaminophen prescriptions and ibuprofen. Laparoscopic or minimally invasive procedures got 5 tabs of 5 milligram oxycodone, along with the Tylenol and ibuprofen. Major procedures got 15 tabs, along with the acetaminophen and ibuprofen again. And then patients that were chronic opioid users or had excessive postoperative pain, we were able to individualize that, and we used 3 times the amount that they used in the 24 hours prior to discharge. And those that, and again, they got acetaminophen and ibuprofen, and we used oxycodone. And anybody that couldn't take oxycodone, we used tramadol. But what we found here is, and what we were able to accomplish here in that our previous average prescription or average pill count on discharge was 30. After implementation of this program, it was down to 11, so pretty substantial drop. And we did not get an increase in the number of refilled phone calls for refill. That was a concern. If we give patients less pills, are they going to be more likely to call back to get refills? And that did not happen. We did patient surveys, and this was a pretty extensive patient satisfaction survey, and what we found was that 96% of our patients were very or somewhat satisfied, so they were not mad or upset about it. And ultimately what we were able to do in this short study, that we decreased by more than 50% the number of pills that were prescribed. And this is just one service line. Our hospital, just with a rough estimate, prescribes about 500,000 pills each year. So we're a big institution, and implementing this on a larger scale could have a huge impact. And back to that study where we looked at opioid use as an epidemic, if you look at that, they also concluded in this that if you can reduce by 50% the number of leftover medications, then you can have a pretty significant impact on some of the outcomes. You can have a 46% reduction in the recreational users, and even a 19%, they projected a 19% decrease in overdose deaths. So improving our prescribing patterns can have a significant impact in our community. And that is the end. Any questions that you have can be directed to Lisa Davis. I believe her email will be on your screens there. And certainly she can pass those along to me. All right.